My name is Olga Kamińska. Hello, everyone. I am the PhD student of the System Research Institute from Polish Academy of Science. And today's topic is the impact of clustering unlabeled data on classification and special case study about the bipolar disorder. So the outline of my presentation is that I will say something about the introduction and the problem, especially in that disease. Then current my methodology and some results of this approach. Yes, so what is bipolar disorder? It's kind of a mental disorder which is characterized by manic episodes and depression episodes. And the patient is diagnosed when he or she will achieve one of those above episodes. So, for example, he was one time in mania and one time in depression. And there's also another state which is called mix, and it's actually one of the hardest states because the symptoms of mania and symptoms of depression can be presented, can appear in the same time. So, for example, he is very energetic, but he or she has no power to talk or to something like this. And there's also the last one state, which is called Epemium. And this state is when the patient is treated as a normal person, but actually this kind of disease, it's a disease for whole life. So if you will become a bipolar disorder patient, you will have this disease for all of your life. And it's also it's quite popular, unfortunately, because 1% of world's population, so thousands of people, unfortunately has this kind of disease. And what else is very interesting that some doctors, I'm not a good doctor, I mean, they are thinking that, for example, patient has a depression, but it actually could be bipolar disorder. So it's very important to have a very good diagnosis of this disease. So how looks our observational study? So in this study, we had about 50 patients which were diagnosed with bipolar disorder, and all of this patient has a dedicated doctor. And this study was conducted in the Department of Affective Disorder in Warsaw, an institute, and also with another clinic in Warsaw. And the patient gets the dedicated smartphone application, and it was installed on this application, and it recorded their mobile calls, outgoing and incoming mobile calls. And on this application has something like the Open Smile library, which translating the mobile recordings, actually first 5 minutes on these recordings, into acoustic features. So we are working only on those kind of features received by this Open Smile library. And on the other hand, the patient met with the doctors every 3 months about visits, sometimes seldom or sometimes more often. And on these visits, they achieved something like the maybe not labels by the score, by two well-known scales. The first one is Hamilton Depression Scale, when a doctor asking about the depression symptoms, and the second one is Young Mania scale, where doctors asking about something like the mania. And when we will connect those two scales, we will achieve those four main bipolar states: mania, depression, euphoria, and also mix. But also there's something like the states between, like hypomania and hypomania and subdepression. But in this case study, we are not taking this sub states into account. Yes, so what was the motivation for this kind of research is that our data are not so perfect because this is the a real kind of data from the real patient with real disease, so it's not so perfect. So we have only not so much labeled data because the patient met with the doctors mostly from 3 months to 3 months. So the number of this label is valid only for the day of the visit. So it's important because the study lasts about 1 year, and for example, we had the patient has 3 or 4 maybe visit in this whole year. So the number of labeled day was so small. So yes, so this was the motivation, and we would like to think about how to figure out with this problem. So let's, for example, look at this table. So, for example, for the first patient, 1472, we had the number of unique bipolar disorder stay. It's only 2. So actually, we had only the 2 changes. To predict the changes, we need much more example. So for actually this the first patient has in total 3 visits in this year, but 2 was different. So he has, or she, I don't remember, has 2 mixed and 1 depression, I guess. So if you look at the number of valid mobile phone in this labeled day, we have only 42 number of calls. So one of our tasks, which I will show you later, is to extend this number of valid days into 7 days before and 2 days after visit. And thanks to this extending, we achieve the number of labeled mobile calls to almost 400. And what's else? We have still more than 1,400 mobile recordings without the labels. And our motivation was not only use the label data, but also add the sum of the data which are not labeled. Okay. So now I will present our methodology. So we are starting with the non-stationary data streams, which are representing voice by the Open Smiles library. So these acoustic features like, for example, loudness or speech in specific bandwidth and something like this. So we are not working on the real mobile recordings. We do not have, for example, the WAV file. We only have this CSV, for example, data streams. Then it's starting to have a first problem because the data aggregation. So we are aggregating all of those frames which are representing the mobile recordings from the first 5 minutes into one recording. So we are using some of aggregation method, and in this kind we are using the mean, the standard deviation, the skewness, and the 3 of quarters, the first, second, and third quarter. So in this step, we are. This is also very interesting question. Which of these aggregates method is will be the best, and which you would like to use? So it's one of the first question of my study. And next, on the other hand, we are extending the label. So it's also one of the second question. For example, the doctor said that 7 days before and 2 days after visit, it's okay. It's also included in some literature and in the available papers, but it could also be depend on the patient, because each of the patient is different. Our approach is patient independent. So this is one of the question: is 7 days before is okay, and 2 days after visit and the day of the visit, of course, it's valid. But for example, when patient starting to be in mania, is very quick. So for example, he or she could be in mania in for example, 2 days. So for example, on Monday he or she feel okay, and on Friday or Thursday, Friday, he or she will have the very, very high episodes of mania. But for example, on the other hand, depression, it's quite different, because depression could start in, for example, 2 weeks. So he or she hasn't any symptoms about depression in, for example, 1st of May, but the depression appear in, for example, 15th of May. So it's also very interesting question: is this extension okay or not? And yeah, next thing what we are doing is feature selection, because the OpenSmile library giving us about 86 acoustic parameters, and we are not sure that all of them are very important. So we are using for all of the patient, and for all of the aggregates method, this RFA methodology, and taking into account the first top 10 most important voice parameters. So we have some sets like for individual patient, for individual aggregation method, and different type of those features. And then we are doing clustering, and this what is important, we are doing clustering not from only the labeled data, but for all of the data from that patient, individual for each patient. So we are taking into account, for example, for the RFA, the number of extended mobile recordings, like 390, and for the clustering 1,400, to include the rest of the data. And for the clustering in this kind of study, we are using the fuzzy semi algorithm, when the number of clustering is the individual number of bipolar disorder episodes. So for example, if patient had 1 mania and 2 depression, we are using the 2 clusters to see is it any different between the mania and between the depression. And to include it into the classification, we are just joining. So we have 2 kinds of classification, with clusters from the whole of the data and without clusters. So we are using only the labeled data, and we would like to see is it any difference between joining the clusters and without joining the clusters. Yes, and the result will be the confusion matrix. We would like to see how they are good classified to the particular bipolar disorder state. Yes, so I finished with the results evaluation, and on the first, my results are about the aggregates method. So for all of the approaches, like for the okay, yes. So the last thing was the classification, and we were using the classification with the 2 classifiers, random forest and SVN, to compare to classify patients into bipolar disorder states. So one was with the joining the clusters, and the second one without the joining the clusters. And I will present some results. So first results are from the aggregates method selection. As I said at the beginning, we are wondering which one aggregate method will fit for this approach. So it turns to be that the mean will be one of the best, the best method, but also the skewness. And it's what is interesting, for example, that the second quartile, is it so important? Yes, and what else? The parameters which characterize normal distribution, like the mean, standard deviation, and skewness, was selected twice as often as the parameters which characterize the quartiles. And also for all of the patient and all of the aggregates method, we saw that the best top feature parameters are also different. Yes, and here are some confusion matrix as our results. So first one is for a random forest classifier. On the left side, we have the confusion matrix without using the cluster information, and on the right side, we have with the cluster information. So we can see that on the left side, without no cluster, so the diagonal will show that 209 were properly classifier, and with clusters 211. So not so much difference, but still an improvement. And the rest of the values are quite similar, or in only one case, I think in depression, there's a slightly increase. And also for the SBN classifier, without using the cluster, we achieved the 203 on the diagonal numbers, and 210 on the with using the clusters. So we also see a slightly improvement. And for this classifier, we do not see that using the cluster receive a worse number of incorrect values. And the overall results are like in those tables. So for both classifier, precision and recalls are for each state are slightly better or very similar when we are using the clusters. This is from the right side, and also for the both classifier accuracy. So the ratio between of the correctly predicted values slightly increased. So our results and our approach is quite okay, but it also needs to be tested on more of the patient. So my conclusion of this research is that unlabeled data have a positive effect on our approach, but it actually should be repeated on the remaining patient. And this approach also taking into account which kind of the aggregated method could be set as the, for example, default of this whole data set. So thank you for your attention. Any questions?
Yeah. So my question is, did you use the number of phone calls as a feature? Because it seems it may be very informative.
Yes, actually we used it on first statistic, like from as our first approach, because we started in this methods some times ago. And yes, it appeared that, for example, in depression, the patient are not calling so much than, for example, in mania, but it also depends because, for example, in mania, some patient decided to, I don't like it, I threw it away from the window, and or maybe then they don't use it. So it's very independent, because the first approach is use the all of the patient into one set, and it's not so good because each patient behave in another way. So, for example, we cannot compare that in two patients into the same set. So yes, we use this kind of statistics, but for the individual approach, we are trying to use the individual methods.
I'm thinking that for you, something in the general direction of active learning could be useful, meaning that, because your problem is that amount of data is limited. However, with time, you may either get additional not necessarily in your specific study, but overall, let's assume that this as a system that you are developing with Professor Katarzyna will be used in realistic settings. Then one of the possible things is that you will have additional data appearing, correctly labeled data, limited amount, but let's say, I don't know, you have 3 or 4 or 5 correctly labeled data a week or one a day because somebody comes to the doctor. I think that you need a method that will to deal with the situation of slow increase of correctly labeled data elements as a one of the research directions.
Yes, it's a good idea. Last time, I was starting with, it was the extreme clustering, because we are, for example, aggregating those data, but when we figure it out, it's actually the time series. So, for example, the frames are looking as a normal time series. So we are trying to streaming, so maybe see the difference not with the aggregated, but with the, for example, one of the mobile pods. So this was last thing what I starting to do. And another idea was with the transfer learning. We are trying to take another calls. It actually will be the recordings from the internet, and retrieve it with the OpenSMI library and compare some maybe not bipolar state on the first data set, but to use some prepared methods to see that, for example, it was a sad recording or happy recording, to connect it with our data set. So we are actually doing some of the methods and have a really lot of things to do.
Okay.
Firstly, I think that this streaming approach with streaming, I'm not sure it will be very useful for you, because in your case it's very irregular.
Yes.
How the data is coming. So it's very hard to find the appropriate window.
Okay, so yeah.
Transfer learning, much more better.
Okay.
So I think this is moreover you can try to generate artificial data with some. Of course, it was just for training.
Yes.
But test on this data which you know that there's a bipolar or not, and so on. But use some artificial data like
Okay. Thank you.
To increase the amount of data.
Okay, thank you very much.